All right, so we're going to start talking about hematology, and then we'll get into oncology at some point in some other slides, and then we'll be getting into our exam for content basically at this point. So what you want to do is you want to look in your Blackboard. There is one PowerPoint that you're supposed to read by yourself. It's considered background information in terms of hematology. So it talks about red blood cells, talks about bone marrow, all of that good stuff. So you want to just look at that and just kind of refresh your mind on all of that information. In this one, we'll focus on anemia. And what you want to do from the very beginning is you want to make sure that you have you have a chart for yourself where you're categorizing the different types of anemia. The two most important categories are under the hypoproliferative. So there's a chart in your book that has all these different categories or classifications of anemia. And under the hypoproliferative, so it's HYPOPROLIFERATIVE. Under that one, it specifically talks about red blood cell production. And then what it does is that it splits that category into iron deficiency anemia versus megaloblastic anemia. So that's important, right? There's a bigger category or bigger classification of everything, but specifically under the hypoproliferative anemia, the two main categories it's going to be iron deficiency anemia, and then it's going to be megaloblastic anemia. So the two types of megaloblastic anemia are vitamin B12 deficiency, and the other one is folate deficiency. So vitamin B12 and folate deficiency are known as megaloblastic anemias. And that word mega means big, right? So those red blood cells are going to be big in size. They're not necessarily going to be the best ones, and we'll get into that in a little while, but they're big. And then for the iron deficiency anemia, think small. All right, so think, and the word they may use is microcytic or microcytic. So it's MICROCYTIC. So therefore, the red blood cells under iron deficiency anemia are going to be tiny. They're going to be small. So right at the very beginning, just try to get that kind of in your head. So the bigger broad categories though in your book is going to say hypoproliferative, it's going to say bleeding, and then it's going to say hemolytic. So there's a chart that describes all of this, and then underneath all of this is going to describe different things that can cause it. So for your purposes, I want you to be very familiar that under hypoproliferative, there is iron deficiency, one category, and then there's megaloblastic, which is also considered a different category. But then we'll discuss them individually anyway, but just kind of try to get a sense of all of that at the very beginning. All right, so anemia by itself, so no big deal here. It's just a deficiency in the number of erythrocytes. It can be described as a deficiency in the quantity of hemoglobin, meaning that the hemoglobin is lower than normal. And then also it can be described as a deficiency in the volume of packed red blood cells. So it's not a specific disease. That's important to know. It's not a specific disease state, but it's a sign of an underlying condition. So in other words, you have to do more research and find out what exactly is going on. So here there are many different things that can cause anemia. So for this particular chart, they've just decided to categorize it slightly differently. They're saying that there are different things that can cause decreased red blood cell production, and they've mentioned all of those things. So how can you end up with decreased red blood cell production? So they said maybe your nutrient intake is not enough. So you're not eating enough iron, you're not getting enough vitamin B12, you're not getting enough folic acid, right? All of that can cause a decreased red blood cell production. Or there's decreased erythropoietin. So that can be tied in with kidney failure in particular, because the kidneys are responsible for erythropoiesis, and that may not be going on. So that's one way. And then decreased liver availability, that could also be decreased iron availability, that could be tied in with liver disease, and that's a problem. So we can get anemia from decreased red blood cell production, and those are the things that can cause it. We can get anemia because of blood loss, and there are so many different things that can cause blood loss. You've been given examples there: hemorrhaging, ulcers, liver disease, colorectal cancer, acute trauma, ruptured aortic aneurysms, and GI bleeding. Fine. How else can we get anemia? So we can get it from also increased red blood cell destruction. So this could be things like hemolysis. In particular, we'll highlight sickle cell disease, and or maybe you had a blood transfusion and it's incompatible blood, and then your blood gets sliced that way. So that's one way. So hemolysis, sickle cell disease, medications, incompatible blood, and then trauma. All of these are different ways where you can get increased red blood cell destruction. So once again, do not overthink any of this. Anemia should be like literally the easiest topic for you guys at this point. And we're also not getting into sickle cell disease as much. I don't even go into it at all, actually. So that should lessen your anxiety in terms of the upcoming exam for this. All right, so now we have anemia. So we're still talking about anemia. We're talking about what is the red blood cell function, what is it supposed to be doing. So it's supposed to be classifying, can't speak. It's supposed to be transporting oxygen from the lungs to the systemic tissues. It's supposed to be carrying carbon dioxide from the tissues to the lungs. So all of that is supposed to be going on. There is the chart I was talking about. I've upgraded the pages for you. So it should be page 923. So they may describe it as hyperproliferative, and that's a defective red blood cell production. They can describe it as bleeding, which is red blood cell loss, and they can describe it as hemolytic, which is red blood cell destruction that's going on there. Your clinical manifestations, so what you're going to be seeing in anemia, are primarily because of the body's response to tissue hypoxia, and primarily because of your hemoglobin levels. So they'll be looking at all of those variables to basically figure out how bad your anemia is. For your clinical manifestations, continuation here. So for somebody who's anemic, think about how they present to you. So they're weak, they're fatigued, or they have general malaise, right? So they're just really, really tired, and they just don't feel up to doing much of anything. If a patient has megaloblastic anemia or they have hemolytic anemia, jaundice may be present in those patients. So that's just something that's unique for those types of anemia. So you want to just know that as well. All right. The tongue may be smooth and red if they have iron deficiency anemia, or it can be beefy red and sore in megaloblastic anemia. So remember which ones are megaloblastic versus which one is just plain old iron deficiency. So under iron deficiency, we're being told the tongue is pretty much just smooth and red. If the tongue ends up being really, really sore in, let's say, iron deficiency anemia, then that means that that's really, really advanced in terms of the depletion of the iron itself. But really, when we're looking at the word sore here, we're saying that it's being tied to the megaloblastic anemias, all right? The corners of the mouth may be ulcerated, and that's known as angular cheilosis in both types of anemia. So in both iron deficiency anemia and in megaloblastic anemia, you may see that the patients have what is known as angular cheilosis. People with iron deficiency anemia may also crave things like eye starch or dirt, and that's known as pica. The nails may be brittle, ridged, and concave. All right, so this is where you start kind of making charts and looking to see what types of manifestations fall under which type of anemia. So what else may you see? The patients may be pale, primarily because of the decreased levels in hemoglobin, decreased blood flow to the skin, jaundice, increased concentration of serum bilirubin. And remember, we tied jaundice with megaloblastic and hemolytic anemia. Pruritus, increased serum and skin bile salt concentrations, and that would be tying that also pruritus specifically with the megaloblastic types of anemias there. All right, but these are just some clinical manifestations that you may be seeing in your patient. I would also tie pruritus with hemolytic anemia, because if your blood cells are getting lysed, that's something that you may potentially see in those patients as well. The cardiopulmonary manifestations that you may see in your patient. So you're going to be seeing increases maybe in your heart rate, because your lungs are basically trying to work really, really hard to provide adequate O2 to the tissues. So a lot of breathing really hard, your heart rate increasing, just because your body is trying to do the most that it can for you. And you know that your cardiac output is maintained by increases in heart rate and increases in the stroke volume, right? To give you the adequate amount of cardiac output. So that's nothing new there. So just some different pictures of patients that are anemic and how bad it can get. Nursing assessment, so subjective data. You're going to collect as much information as you can from the patient, what they're telling you. You're going to be looking at their past health history. And so far, I'm not saying anything really that you wouldn't be doing anyway. Like, this should not be strange or bizarre for you. So looking to see if they're on any medications, looking to see if they have any surgeries, other types of treatments, dietary history. So you think of anything that can cause anemia. And we already discussed all the different things. So it could be dietary, just decreased red blood cell production itself, or maybe there's red blood cell destruction, whatever. It doesn't matter what it is. So you're going to make sure that you're really doing an important assessment of your patient, and you're going to assess how all of that is affecting the patient. How functional are they? Are they fatigued? Are they tired, exhausted? Right? So you're going to be doing all of that as part of your assessment. You are looking at some of your potential nursing diagnoses. So what you're going to find is that some of these pages have changed because I've adjusted them for 14th edition. So things like fatigue, altered nutrition, less than body requirements, ineffective health management, ineffective tissue perfusion, non-compliance. So none of that is strange or weird in any way. Like, all of these should make sense to you. Some of your collaborative problems include things like heart failure, angina, confusion, injury related to falls, and a depressed mood. So anything that's collaborative, once again, it means other disciplines are involved. So if somebody is depressed, obviously maybe psychiatry or psychological consult needs to come in to kind of try to help. Injury related to falls, maybe people that come in with to help the patient walk, or to give them devices so that they're able to walk, like a wheelchair or something. So all those different types of disciplines have to come in. A heart failure, if the patient's bleeding profusely, right? So now maybe you may need a cardiac person to come in also to be on the team, so that you're making sure that the patient is getting all the collaborative treatment that they need to be getting. So all of this is things that you want to make sure you're looking into. So your main goal is you want to assume no more ADLs to the patient. You want to make sure that they're getting adequate nutrition, as always, and you want them to develop absolutely no complications to anemia. So all of this, you guys know, this should not be like anemia should not end up being a complication. Blood or blood product transfusion. So your nursing implementations, what do we have to do? So depending on the cause of the anemia, that's basically what we're going to be focusing on. So is it blood or blood product transfusions that they need? Is it drug therapy that they need? Is it volume replacement? Is it dietary and lifestyle changes? So you are going to focus on what the issue is, and you are basically going to try and make sure that you are managing it from that perspective. All right, so oxygen therapy goes without saying, patient teaching, if that's what's required, nutrition intake, compliance with safety precautions to prevent falls and injury, especially if they're tired, if they're exhausted, if they can't get around by themselves. You know, you're making sure that you're targeting all of these things. You're looking at the older patient, always. So it's very common in older adults. And anemia is like apparently is present in people, like at least 50% of older adults, right? Just because they have so many other conditions that are a problem for them, or maybe they're not eating as well as they need to be eating. So just a lot of different issues. So they have chronic disease, they have nutritional deficiencies anyway. So you're kind of just expecting this to be an issue in older people, and at least about 50% is what your book is saying. So what are you going to see? So they may be pale, confused, ataxic, so they're dizzy, off balance, they're fatigued, they're maybe having things like angina, having things like heart failure problems, if that is the type of anemia that they're having. So you're just really, really monitoring all of this. If there's blood loss involved, so just think of all the different types of anemia once again, and you're trying to see what is going on with your patient specifically, right? So signs and symptoms may go unrecognized or may be mistaken for normal aging changes. And unfortunately, older people do not respond to anemia as well as young adults, because they have increased risk for falls, they have increased depression, and they have decreased mobility. So all of that is something that you as a nurse have to make sure that you're targeting, to make sure that you are providing your patients with the best nursing care that you possibly can. So for a fact, you know that diet for them is a really, really big deal. So you want to make sure that you're really, really watching everything. All right, so now we're going to start kind of talking about the different types of anemia specifically. So now we're targeting iron deficiency anemia, right? So this one is specifically tied to several different types of things. So we're going to start paying attention to see, okay, what is happening here. So for iron deficiency anemia specifically, we are noticing that it is could be maybe because of inadequate dietary intake. They're not getting enough iron absorption that should be going on. Or maybe it could be also be because of malabsorption, it could be because of blood loss, or it could be also because of hemolysis. All right, so we're going to unpack some of these things and kind of talk about them a little bit more. We know that iron absorption happens the best in the duodenum, all right? So anything that's affecting the duodenum, any type of malabsorption that's specifically involving a disease of the duodenum, where the absorption is not going to happen, that's going to be a problem. We know that in terms of the blood loss, it could be because of things like peptic ulcers or maybe gastritis. Maybe they have things like diverticulitis or something like that, right? So anything that is an issue could potentially be a problem under blood loss. And then for the hemolysis, they specifically talk about patients that may have things like chronic renal failure, and those patients that are getting dialysis treatment on a frequent basis, they tend to lose a lot of blood sometimes just because of getting dialysis done. So it could be because of the dialysis equipment or because of frequent blood sampling. Like all of that could be a factor. All right, so malabsorption specifically because of the duodenum issues, maybe you're bleeding because of GI conditions that we've talked about already, or maybe hemolysis because you're specifically getting things like chronic renal failure and you're getting dialysis, etc. So don't overthink any of this. Just try to think if anything makes sense to you if you think about it. That's it. All right, so in terms of your general manifestations of anemia. So once again, very, very boring. Nothing for you to be overthinking at all, once again. So we can look pale, which is common. They can get things like glossitis, inflammation of the tongue potentially. So it doesn't mean you're going to be seeing all of this in everybody once again. All right. It depends on how advanced this condition is in everybody. So chylitis, which is inflammation of the lips, angular chylosis, corners of the mouth are ulcerated. They can get things like headaches, paresthesias, burning sensation of the tongue. So for iron deficiency anemia in particular, if it's really severe or prolonged, that's when you're getting kind of like where the tongue now is smooth, it's sore. Keyword being sore there. They're getting the brittle and ridged nails. They're getting things like angular chylosis. And once the patient starts getting iron replacement therapy, some of these things start kind of decreasing once again, right? Or they start subsiding. So depending on how advanced the iron deficiency is, that will kind of drive what the clinical manifestations are going to look like. Okay. You have a couple diagnostic studies that you need to be looking at under iron deficiency anemia. So you are going to be looking at hemoglobin, hematocrit, MCV, serum iron, as well as the ferritin. And the short answer is all of them are decreased, right? So decreased hemoglobin, decreased hematocrit. Your MCV is the size of the erythrocytes. So when you do not have enough iron, your erythrocytes are going to be small, all right? If you don't have enough iron, your serum iron levels are going to be decreased. If you don't have enough iron stores, like extra iron, your ferritin levels are going to be decreased as well. So that's what the ferritin number is. So that's your extra iron stores that you would need for whatever reason, right? So if your stores themselves are decreased, then you're going to have decreased ferritin levels there. And then you have other studies that they can do, so endoscopy, guaiac, colonoscopy, bone marrow biopsies, etc., just to see whether or not you have iron deficiency anemia. But for your purposes in terms of labs, so hemoglobin, hematocrit for sure, MCV, serum iron, and ferritin levels. All right. So you want to treat whatever the underlying cause is. What is it that's causing the decreased level of iron deficiency anemia? Like, what is the issue? So either you want to increase the intake of iron via ferrous sulfate, oral or occasional parenteral iron supplements as needed, transfusion of packed red blood cells, and nutritional therapy, which we're going to talk about in the next slide. So find out why is your patient having iron deficiency anemia. What is the problem? And then you try to fix that. So this particular slide has all of the different types of, let's see, the food sources, right? So for this particular iron deficiency anemia, we're going to focus on iron here. So we have hemoglobin synthesis, and we're going to look at the particular foods that can give us a lot of iron. So we've been given examples here. So liver and muscle meats, eggs, dried fruits, legumes, dark green leafy vegetables, whole grain and enriched bread and cereals, all of that. So depending on which deficiency anemia we're talking about, you can refer back to this chart as well to see, okay, if I'm talking about vitamin B12 deficiency, what are the things that will give me, what are the food sources that will give me vitamin B12? And if we're talking about folic acid, what are the things that will give me folic acid? So this is just your reference to look at. If we're talking about vitamin C, what are the foods that will give me those particular things, as well as whatever else is in your book as well. You want to look at that also, but have a good sense of which food sources are adequate for which particular deficiency that we're talking about. In terms of the drug therapy for iron deficiency anemia, what are you going to focus on? So the oral form of iron is inexpensive, it's convenient, so that's usually how they'll start treating the patient. So maybe they'll give the patient ferrous sulfate right off the bat, and that will increase your hemoglobin in a few weeks. You can maybe take the ferrous sulfate for I don't know, anywhere from 6 to 12 months, and that may be enough for the patient to get better, and that's fine. You want to make sure that you're not giving enteric-coated or sustained release capsules, because that can be counterproductive, because the whole idea is you want them to take the medication and you want it to get absorbed in the duodenum and the proximal jejunum. The thing is, if you give them enteric-coated or sustained release, it's going to bypass the duodenum and the proximal jejunum. Is going to go further down the GI tract, and it's not going to be necessarily absorbed as well as it should be. So that's just something to consider. Or if you have to give an enteric-coated or sustained release, you may end up giving a bigger dose, just to account for the fact that it's not going to be as well absorbed where it ends up. So daily dosing can be 150 to 200 milligrams, and your doctor will come up with the exact amount. So it's best absorbed as ferrous sulfate in an acidic environment. So you may want to give things like OJ with it, because all of that will help with absorption. Your part of your teaching is that it's going to make this stool dark, and that's normal. So you just want to make sure you've taught your patient that. If it's liquid iron, you want to dilute it, and you want them to use a straw because it can stain your teeth. Some of your side effects include things like heartburn, constipation, and diarrhea. You want to make sure that they're not taking the iron with antacids or with dairy, because that can also decrease absorption as well. You can take the iron with a meal if the patient has GI distress, so you can give them something with it. Um, if they're maybe nauseous or something, and if that's going to help. Um, but ideally, if you're taking it with food, it's going to diminish the absorption by even as much as 50%. So it's okay for you to take it on an empty stomach, that's fine. But if they can't do that, then you can give it to them with food, but know that that could decrease the absorption. But you may make up for that maybe by the doctor making sure that they maybe give them a higher dose or something like that. So those are just different things to consider as well for the patient when the doctor is making the final prescription. For the parenteral drug therapy specifically, so this is when they can't take PO for whatever reason, right? So they have malabsorption issues, they can't tolerate the iron, PO, and maybe you need a lot of iron beyond your normal limits, or maybe there's poor patient compliance, like they're just not following your directions. So then you may have to end up giving them parenteral iron. So you can give this either IM or IV. And the IM may stain the skin. So this is where you end up with the Z-Track injection technique method, right? So you want to use a separate needle for withdrawing the solution and for injecting the medication. So these are just different things that you have to think about. For iron deficiency anemia, we do have some groups that are considered at risk. So we want to make sure that we're targeting them closely as well. So premenopausal women, especially those that have excessive periods, you want to make sure that you're meeting their iron needs. Pregnant women, so you just need more iron when you're pregnant anyway. So you want to make sure that they're getting adequate iron supplementation as needed. People from low socioeconomic backgrounds, older adults in general, they're not eating right sometimes, and they may have other issues that maybe they have malabsorption issues on top of that as well. Individuals experiencing blood loss. So you just want to make sure that you're really doing an aggressive assessment and targeting all your at-risk groups. I would add chronic alcoholics here for sure. And anybody that has things like ulcers, gastritis, GI tumors, inflammatory bowel disease, any of those patients would be considered your at-risk populations as well. So a lot of diet teaching, so that goes without saying. You're basically looking to see, okay, what happened with these patients? Why do they have iron deficiency anemia? So you are going to target that in terms of your treatment, right? So teaching, supplementing with iron, discussing your diagnostic studies, emphasizing compliance. Iron therapy may be needed maybe for 6 to 12 months after your hemoglobin levels return to normal. So because you want to have like a store of iron, so you may want to still keep giving them more iron just so that you have a ferritin level that's where it should be, right? So that your iron stores are not depleted. All right, so you may continue iron therapy, in other words, for 6 to 12 months, even after hemoglobin levels have returned to normal, because you want to have enough in your storage, in your bank, so that they don't go back into being deficient quickly. All right, so now we're going to talk about the megaloblastic anemias, right? So these are a group of disorders caused by impaired DNA synthesis. They are characterized by the presence of large red blood cells, so that, hence the name megaloblasts. They are easily destroyed because of a very fragile cell membrane. So in terms of the deficiency, we're specifically talking about cobalamin, which is vitamin B12, as well as folic acid. So unfortunately, for the megaloblastic anemias, they are abnormal and they're easily destroyed in the marrow, and the ones that do leave the bone marrow are decreased in number. All right. So unfortunately, you can end up with like things like pancytopenia, and that is definitely not a good thing. So abnormal, easily destroyed in the marrow. The ones that do leave the marrow tend to be decreased in number, so you can end up with things like pancytopenia. If in a very, very advanced disease, your hemoglobin can be like 4 to 5. So these are just other things that can happen. Your hemoglobin can be 4 to 5. Your leukocytes can be 2,000 to 3,000. Your platelet counts can be even less than 50,000. So that's when the patient has things like pancytopenia. So depending on how advanced the disease gets, you can get some really, really bad things happening from your megaloblastic anemia. So just something for you to know that can happen as well. So we're first going to target specifically, cobalamin deficiency. And so we're specifically talking about intrinsic factor. So we know that it's a protein secreted by the parietal cells of the gastric mucosa. So all of that information, guys, you have to be able to tie everything in. So we've had a pretty good foundation of all of this from before. So now you're bringing all of that information and making sure that everything is making sense for you. So you know already that intrinsic factor is required for cobalamin, vitamin B12 absorption in the small intestines, right? So that is not anything crazy here. You know that you need intrinsic factor. So how might somebody end up with cobalamin deficiency, right? Well, if they do not have intrinsic factor, right? Because you know that in order to have vitamin B12 absorption, you need to have intrinsic factor. So if you do not have intrinsic factor, you are going to have cobalamin deficiency, and that can be termed pernicious anemia, right? Then you think of, okay, what are some of the reasons why I may end up with vitamin B12 deficiency? So if you've had gastrectomies or if you had GI surgery, and we've discussed under what conditions all of this can happen, right? If you've had chronic diseases of the GI tract, right? If you've had nutritional deficiencies, and the nutritional deficiencies are rare, but they can happen in people that are very, very strict vegetarians. That is how that comes into play here. If somebody is a chronic drinker, so they have chronic alcoholism, that can happen here as well. If a patient has hereditary enzymatic defects going on with them, that is something else that can be a factor. If the patient has long-term users of H2 histamine receptor blockers, so apparently if you're on H2 histamine receptor blockers for a very long time, that can also inhibit B12 absorption. Things that can cause faulty absorption of vitamin B12 include things like Crohn's disease, if you've had an ileal resection, if you've had a bariatric surgery, a gastrectomy, if you're taking medications like a glucophage, metformin, that can also decrease your B12 absorption. So these are just all the different factors, and you have to be able to read this and kind of think for yourself, okay, I think I can see why that is happening. All right. With the pernicious anemia, apparently it happens in a lot of people with Northern European ancestry, specifically Scandinavians, and it also happens a lot in African Americans. So this is just something to know in terms of your patient teaching as well. All right. So for your cobalamin deficiency clinical manifestations, what might we see? So you're going to see your general symptoms of anemia that we've already mentioned. So that includes things like fatigue, being tired, being pale, any of those manifestations that we talked about. Unfortunately here, so this tends to be insidious as well in terms of how progressive the manifestations are going to be. So it takes time for it to happen. So if your B12 is depleted, it's slow and insidious. then the anemia is progressing, you may start seeing worse things. So you're going to be seeing things like a sore tongue, anorexia, nausea, vomiting. Maybe you're seeing things like abdominal pain. Specifically for the pernicious anemia itself, the tongue is going to be smooth, it's sore, it's red. You may have things like mild diarrhea that may be also happening in your patient. All right. So general symptoms of anemia are true pretty much across the board for everybody. And then you just kind of want to start seeing, okay, what is unique about each particular condition. Your neuromuscular manifestations that you may see, right? So we did not necessarily see the word neuromuscular under iron deficiency anemias, right? So we're seeing neuromuscular under vitamin B12, right? Specifically at this point, right? So what does that look like? So it's weakness, paresthesias of the feet and hands, altered position sense, ataxia, muscle weakness, and impaired thought process, right? And once again, this may take a while to build up. So I want you to start noticing, okay, what is different about each of these deficiencies as we're going along. So in terms of the testing for cobalamin deficiency, so you're going to look at several things. I'm going to highlight the first 3 bullets and the last bullet. So you're looking at the last bullet specifically for anti-intrinsic factor antibodies, because that's going to factor into whether or not your patient has things like pernicious anemia, right? And then you're also going to be looking at the shape and the size of the red blood cells. So they tend to be microcytic with abnormal shapes. You're also going to be looking at your serum cobalamin levels. And you're going to, obviously, it's going to be decreased if they have a cobalamin deficiency. And there's also what is known as a positive Schilling test that you're going to look for. And that all that does is you look to see if the patient is absorbing the vitamin B12 properly from the GI tract. And it's a whole bunch of different tests that they do. Like I think it's like 4 different phases of this thing. And they really are not doing a Schilling test as much anymore. They tend to kind of just look at the serum levels of the cobalamin. So those are the main things that I would highlight under cobalamin deficiency in terms of the diagnostic studies. So it can be treated by the, in terms of collaborative care, it can be treated by vitamin B12 replacement. Vegetarians can prevent or treat deficiency with oral supplements with vitamins or fortified soy milk. If it's due to common defect in absorption or the absence of intrinsic factor, replacement is by monthly intramuscular injections of vitamin B12, right? So you have no other way to get it, so you need to get an injection for that. And as your B12 is replaced, your reticulocyte count rises within 1 week, and in several weeks the blood counts are all normal, which is what you want. Your tongue is going to feel better, it's going to appear less red in several days. The neurologic manifestations will require more time for recovery, especially if there's severe neuropathy, etc. So you just want to let the patient know that it's going to be a process that takes some time for them to get back to normal, right? So they need to be patient with that. You are looking at the familial disposition. Early detection and treatment can lead to reversal of symptoms. So you just want to find out, what the patient's history is very, very early on. You want to ensure that the injuries are not sustained because of the patient's diminished sensation to heat and pain. So remember, this is where they have neuromuscular manifestations. So they have things like even paresthesias, right? So that whole mechanism of where they're able to know whether or not something hurts them is kind of diminished, or it can be hypervigilant in some cases. So you just want to make sure that you're really, really monitoring your patient closely, so that let's say they're about to take a bath and they can't tell whether or not the water is hot, right? So safety, 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 telling them they should not be the ones that are going to be checking whether or not the temperature is hot or cold with their foot, right? Because they don't know how to do that anymore. They may have these paresthesias, or it may be too much for them. So just the fact that the bigger point is just the fact that there's diminished sensation to heat and pain. So making sure that you're protecting them from that, ensuring patient compliance, all of that needs to be talked about, and you're evaluating whether or not your patient has anything like gastric carcinomas, just to make sure that they're not now a risk factor for that as well. Because that would just definitely make things worse for them. All right, and then we're getting into folic acid deficiencies. We already know that it's also a megaloblastic anemia, and we know that we need folic acid for DNA synthesis, and we need red blood cell formation and maturation, essentially, for all of this to be working properly. So your common causes for folic acid deficiency are things like dietary deficiency, malabsorption syndromes, medications. So here specifically for folic acid deficiency, those meds include things like methotrexate and any anti-seizure medications. So things like Dilantin could be a problem for us under folic acid deficiency. If the patient has chronic hemolytic anemias, if they have alcohol abuse and anorexia, and the same things we talked about earlier under loss during hemodialysis, that could also be a factor here. If they're pregnant, you want to just factor that in because you want to make sure that they're getting more folic acid at that time, and that's something that we already mentioned earlier. So in terms of dietary, they could not be eating. So making sure that they're eating properly, making sure they're getting a lot of greens, a lot of liver, all of those good things. So this is where diet is a big deal. Once again, you're looking at your chart and you're teaching from that aspect. Things like celiac disease, right? You're monitoring if your patient has any of those issues, because those kind of factor in with the malabsorption syndromes as well, where they're not able to absorb folic acid properly. So you're looking at all of that. So folic acid deficiencies, so they are similar to those of cobalamin deficiency, but your patient does not have neurologic problems. The onset is insidious, and you're going to treat them by giving them replacement therapies, whatever that looks like. And you're going to encourage the patient to eat foods with large amounts of folic acid. So all of that is going to happen for your patient. So your nursing management, what does that look like? So inspection of the skin, mucous membranes, and the tongue. Mild jaundice may be apparent. Vertigo, premature graying of the hair, often seen in patients with pernicious anemia. So we're specifically highlighting our megaloblastic conditions at this point. You're paying particular attention to ambulation, gait stability, and the need for assistive devices, canes and walkers, and for assistance in managing daily activities. Physical and occupational therapy referrals may be needed. If sensation is altered, the patient needs to be instructed to avoid excessive heat and cold. Mouth and tongue soreness may limit nutritional intake. The nurse advises the patient to eat small amounts of soft, bland foods frequently. So I'm actually going to stop the PowerPoint here, and then I'll do the other stuff in a different PowerPoint, because then if it's too long, it doesn't upload to Blackboard like it should. And once again, we're not covering sickle cell at all. All right.